We're going to move to our next session, which is employing innovative technology to enhance value and reduce waste. We're going to be joined in the order of Mike Chernew from Harvard, Jeremy Fries from Humata, and Hannah Naprash from the University of Minnesota. And what we're asking our folks to do here in this session is self-introduce, as always, the brief self-introduction, and then 8 minutes of your best stuff that addresses employing innovative technology to enhance value and reduce waste. And if we do that, we'll have some time at the back end for discussion among the 3+1 of us, and maybe even take a question or two. So, Mike Chernew, just going to you first, Mike. I'm wondering if you don't mind, you have a kind of, can you riff off a little bit of what you just heard from Abe Sutton? Any kind of instant reactions to what he put across, and then give us your balance of 8 minutes after that, Mike.
Yeah, so my reaction is I wish I didn't have to follow him. I don't know if that's like a valid reaction. A lot of the themes I'm about to talk about, I think are going to be themes that Abe raised, and I think it's reasonable for people in the audience to say, boy, they have a lot going on, and that fits in exactly what you're saying. So I think that's right. I think what I'm going to do is I'm going to run through what will be somewhere between 8 and 80 minutes, and build off on what I think is going on the topic at hand, and I'll try and call out areas that relate to the things that Abe said. But I think it's very clear that the Innovation Center is extremely active overall, but also in the specific issue of how to leverage payment models and other strategies to get the most out of technology. So, with that, um, I think the biggest context that I think needs to be kept in mind is we face an affordability crisis in the healthcare system. With national health expenditures, they've been growing about 7%. They're projected to grow between 5 and 6%. That's just a rate of healthcare spending that we're not going to be able to sustain. So I do spend a lot of my time focused on value. I think I believe strongly that the healthcare system needs to provide access to high value services to um, patients that need them. But I think that we can't use the appeal to value as an excuse to ignore the core fiscal challenges. And frankly, I think the fiscal challenges are what's going to drive a lot of policy. And I think, as Abe sort of alluded to, he sees and I see technology as a core mediator to enable us to try and meet those challenges. So I should note technology is not just AI. There's drugs, there's a whole bunch of other types of technologies that get done. Um, but AI is probably the sexiest, and I'll probably focus on AI just because that seems to be the topic of the day. Um, so what I'm going to do is I'm going to talk about four different ways that technology, AI in particular, might affect the healthcare system. And the theme of this is I'm going to point out the optimistic story and then the pessimistic story. And then I'll say something to sort of close in each one. So the first will be, broadly speaking, reducing administrative costs. And there's several ways that AI can do that. There's the obvious, just reduce labor. We don't need as many people in HR. We don't need as many people in customer service. We don't need as many people doing the things that people do that now we can get AI enabled services to do. And that should make things cheaper. Related to that is uh, we can use AI to help on the purchaser side identify things that we don't want to have happen. So, for example, if you think providers are coding very aggressively, you might be able to use AI to identify that and ultimately end up saving money. So that's sort of and you could do that administratively cheaper with AI and other tools that help essentially more efficient purchasing of care. On the other hand, if you're sitting on the provider side, you can use AI to code more aggressively. You can identify more sepsis cases. You can identify patients who would have been coded a 99213, which is an average visit, and you can get them to code 99214. Now, Hannah's going to talk, and she's doing actual work in this area, so I'm not going to say much more than that, except you could do that. And so it's not clear what the ultimate impact is going to be on kind of the admin of healthcare. And that's a sort of point one. Point two is you can use AI to support physicians. So on the plus side, you can use AI to better triage. You can give people Imaging procedures, you can run AI through them. And again, Hannah's going to talk about this. So the theme here is Hannah knows more than I do. But just to set her up, you can do this type of triaging with imaging and hopefully avoid some things that you didn't need. I'm astounded and mildly offended that Abe didn't mention Wiser, but you can use technology to reduce low value care. And maybe this is true for everything. I would say Abe has a model for that. In this particular case, it's a model called Wiser that facilitates prior auth to reduce unnecessary services. You can also support the doctors by streamlining the workforce. So you might not need as many clinical personnel. You could have AI chatbots or others try and do some of the care that otherwise might have been being done by a human and avoid certain types of care. So you can support the clinical enterprise of a medical office, for example, using AI, all of which you would think would make the case for lower spending, which is true. But I don't think we should underestimate the potential for AI to increase utilization. So, for example, you run a bunch of things through AI, you think it's going to streamline things, but maybe that means you need more images. If you want to run, so it turns out, and I know nothing clinically, but if you want to run an image through AI, someone's got to do the image. So you're spending more money on the CT scan so you can run the CT scans through the AI or whatever it is you happen to do. And of course, the CT scans, or for that matter, the AI, can identify stuff that might not have been identified, and you can end up using more care. So, Harry Truman wanted a one-arm economist, and that was even before listening to this talk. But the point is, my entire talk is going to be on one hand, on the other hand, and you can see that in the supporting doc section as well. So someone's going to say, and I think appropriately, you can also use all these tools to support patients. So on the plus side, you can, for example, support choice and competition, say amongst MA plans or Part D plans, or a whole bunch of other types of choice. And the more you can use these tools to support choice, the more competition you have. The more competition you have, the lower prices would be. And generally, and I say this as an economist, sort of the better the world is. And AI can certainly help that. You can use AI to support the patients avoid unnecessary care seeking behavior. So before I was talking about doctors triaging better, but here you might have patients that have some sort of rash or whatever they have. They've hurt their elbow, or I don't know. You have a lot of body parts, all of them can get hurt. And I think no matter what gets hurt on your body, you can ask AI what it is. And maybe I will say, that's a really good question. This isn't a problem. If you don't have a fever, take an aspirin and stay away from the doctor. And if the alternative was go to the emergency department, you've saved some money because now AI just did that patient level engagement, and it just becomes a better way to do things. And I think to some level, the access model that Abe talked about tries to do versions of that, right? It tries to engage patients in managing their disease better in ways that are just cheaper. And so it's ultimately supportive of patients. On the other hand, you could end up in a situation where people go into the doctor and they say, Chat told me that I need to have a full body MRI scan. I probably wouldn't tell you that, but Chat said this, that, or the other thing. And you can envision a world in which all the AI induces patients to seek more care, to engage in certain ways that can ultimately be more expensive, particularly depending on who's managing the AI. And I'll get to that point in a minute. So that's the third one. So admin costs, supporting the doctor, supporting the patients. And the fourth one, which is a little bit different than the other three, is you can use AI to support drug development, or drug testing, or a whole bunch of other things. And I think it's pretty clear that with AI, you can do innovation better. And in general, if you do innovation better and cheaper, you're going to save money. You may even get better drugs, and the drugs may have better offsets. So if you develop better drugs and you can avoid treating diseases you otherwise would have treated, you could save money. So there's a lot of advantage, I think, in AI in saving money if you follow that pathway. And I do believe that's a legitimate pathway. But I guess this is the refrain. On the other hand, you just might get a lot more drugs. And those drugs just might be expensive. And they might be very personalized. So you get a drug for someone who, Mark at the beginning said I look the same, and he was mocking me because he knows I'm going to get on camera and people will realize I don't. But the point is, there's going to be drugs for just, aging academics. And those drugs end up being expensive. And so if you just get more drugs, you could do more things. And if you get more expensive drugs, you're going to end up spending more. That's not necessarily a bad thing, by the way, just to be super clear. That could be a great thing. But to my entry to this whole talk, we really have to think about the fiscal effects and the fiscal challenges, because we're not going to be able to fund 5-6% growth on an ongoing basis. So my last point, and this relates a little bit to what Abe said about the lead model, and I think actually the theme of what Abe was talking about is the way this is all going to play out, how much we stay on one hand or the other hand, whether this saves us money and brings us to nirvana or costs us money and creates a crisis, depends on the systems and structures and incentives that we put in place to use these technologies. Technology itself is a tool. It's not going to save money or cost us money. It is going to be used by entities. It's going to be used by entities that are using it to accomplish things that they are incented to accomplish. So if we set up a system where people have an incentive to use AI to make the healthcare system higher quality and lower cost, you will probably skew the technology and frankly the winners in the technology space towards the types of technologies that save money and improve outcomes. But if we have a world that incents folks to improve risk coding or manipulate quality measures or get more people to have X, Y, or Z, you will have AI technologies that support the actual doing of that. And
So,
so,
Mike,
yep,
I want to make sure we capture. So you've covered.
and I'm done,
You,
by the way.
okay, good. I just want to make sure I didn't miss anything. Number one, use innovation and other innovations to lower administrative costs. You gave us pros and cons. Number two, supporting physicians, including through Wiser, pros and cons. Number three, support patients and patients' choice, pros and cons. Support new drug development, pros and cons. But then you wrapped it with saying all the AI and these other tools aren't the ends in of themselves. You can use AI to manage, for example, the right incentives.
So,
I want
well,
to make
actually,
sure we
I would
do
have said
that.
it differently. I would have, so I just missed the very end, and I am at the end. I would have said whether you get the pros or the cons depends on how you set up the incentives.
Perfect. Okay. So that's the incentives angle applies to all four of the above.
Yeah.
Good. Points very well taken, Mike Chernu. Thank you very much. Hannah, can we go to you next? Remind people about your role at the University of Minnesota and is it the Gophers, the Golden Gophers?
It is the
It is.
Gophers.
Yes.
Well done.
Okay. All right.
Go Gophers.
Yes.
My name is Hannah Neprash. I'm thrilled to be here. I am a Harvard-trained health economist and currently an associate professor at the University of Minnesota's School of Public Health. And I'm here to talk today about I would say my current obsession, which is understanding what AI means for the future of healthcare spending and spending growth. So with any luck, I won't duplicate too much what Mike said, but rather building on it. Cliff, I trust that you will hold me honest on that account. So if anybody tells you that this is an obvious question with an obvious answer, they're lying to you. I really do think that we don't know yet what AI will do to system level healthcare spending. But I want to start with the glass half full story here and share a few ways and a few specific applications in which AI has the potential to either actually reduce healthcare spending or at least slow down the growth of spending. So the first, and this is one that already came up with Mike, is by simplifying all of the incredibly annoying administrative tasks that are necessary and certainly are not going anywhere within healthcare. Popular use cases right now that apply AI in this area are call center automation and AI enabled prior auth. So I'm really glad that we'll hear from Jeremy next. Most of the potential spending reductions here come from what Abe was talking about, and that is essentially increasing productivity, deploying the human workforce in healthcare more efficiently. That can come with some growing pains, right? There may be some job displacement, some retasking. If AI reduces administrative tasks for physicians and other clinicians, it also stands to decrease spending by reducing the burnout-driven turnover that we see in healthcare. So anytime I go to the doctor, I really like to just innocently ask, so how do you feel about your current documentation burden? And then we have kind of an impromptu therapy session, and it's filled with lots of totally understandable rage, but recently I've been going and I've been hearing a completely different story, which is that they're using an ambient scribe that employs generative AI to listen to the clinical encounter and then draft a clinical note. It doesn't take out the clinician from the equation, right? There's still a lot of editing that has to happen for the documentation, but it seems to really make clinicians meaningfully happier. And if you can make clinicians happier, a happy clinician is less likely to burn out, less likely to leave their practice, which will, of course, require an expensive, leaves you with an expensive hole to fill, basically. So that's another potential way that AI stands to improve job satisfaction and reduce healthcare spending. I think the big one that I haven't heard a ton about yet, but well, that's not true actually, because this is in the access model as well. By accelerating diagnosis and preventing the progression of disease. So here's an example for you. AI-enabled coronary artery disease algorithms will take in a coronary CT. In under a minute, they will output a 3D model of the patient's coronary arteries, including specific information about where there may be stenosis happening. Sclerosis. So for patients with the right risk profile, this application of AI can obviate the need for a much more invasive test, meaning that patients can get diagnosed sooner, facilitating lower cost treatments like lifestyle modifications and statins, rather than the really high cost stuff when somebody has a heart attack or another adverse cardiac event, if that coronary artery disease is left untreated. So here I think I will emphasize that it's really important for us to understand better how all of these FDA-approved clinical AI applications, of which there are more than 1,300 right now, how they work in the wild, rather how they worked in clinical trials, because it's not always going to be the same thing. And Mike and I have actually studied the coronary artery disease AI application and found that encouragingly, clinicians substitute away from the invasive testing option, but that diagnostic spending increases, in large part because of the way that Medicare prices the AI option along with its imaging, the necessary imaging input, as opposed to the more invasive option. But with that all said, it's maybe not a bad story, because there's some suggestive early evidence that that cardiac adverse events actually fall after clinicians adopt the AI-enabled detection here. So suggesting potentially higher value. Of course, it's still early days here. So that was my glass half full. Now I'll switch to the glass half empty, which I feel like is my more natural state as a health economist who's always on the lookout for unintended consequences. The first thing to point out is just arithmetic, really, right? So as AI expands access to care, that also expands the population of patients who are diagnosed and need treatment. A really good example here is going to be autonomous AI diagnostic systems for diabetic retinopathy, which we know is a condition that patients with diabetes should be screened for annually. And it's like not even 2/3 of patients today get that care. Now there's an option that is, again, autonomous and FDA approved. There are actually, I think, 3 versions of this that have FDA approval, where there's no physician needed. You don't need to find an ophthalmologist or an optometrist that can see you. Basically, all you need is the AI-enabled medical device and a medical assistant who can take that picture of your eye. That's fantastic, and it really expands access. But as people get more of the recommended care, more will be diagnosed. It increases the population of patients who do require treatment. Okay, that's just the kind of the algebraic one. Here are the 2 things that keep me up at night. I worry that a lot of the current clinical AI applications have the potential to generate what I would call a care cascade, which is really the opposite of value. By providing clinicians with a second set of really good eyes, right? AI can detect more than maybe an individual average clinician would detect. And when you find more stuff, you have to chase it down, whether it is or is not going to be clinically meaningful, and whether it's going to affect the patient's treatment plan. An example here would be AI-enabled colonoscopy, which in real time helps gastroenterologists detect polyps. It's supposed to increase by 14% the polyp detection rate. that is a boon for the practices that adopt AI because they can build diagnostic colonoscopies instead of screening, and they can send all the polyps to the lab for pathology revenue. But it's tricky for patients, right? Because that means more spending for patients as well. And if that's high value clinical spending, that's great. If it's not, it's something to at least have on our radar and be a little bit more worried about. There are also some opportunistic screening tools that are using AI to go back and reanalyze existing images. Sometimes the patients don't even know about that. So going back through a CT that was originally for, I don't know, kidney stones, and looking instead for whether there's any sign of low bone mass. That is an application that is being used today. Again, that might detect something meaningful and earlier before it would otherwise be detected, or it has the potential to generate a lot of spending and stress that might not be clinically meaningful. We just need more research to understand, and we need to build the right incentive system. The last thing I want to say, I promise, I'm almost taking more time than Mike here, which is shocking.
okay.
I know, exactly.
That's okay.
And this has come up as well, and I guess I call it in my head, I call it the AI coding wars. The most prevalent non-clinical AI use case right now is something related to billing, whether it's in the context of a revenue cycle management tool or part of, built into an ambient scribe. And the idea is that, and this is how AI developers advertise it too, is that they can essentially optimize the coding, the diagnostic, and the billing code, service coding. So Mike gave the example of justifying a level 5 evaluation and management visit instead of a level 3, or bumping up the severity of an MSDRG for an inpatient admission. And if any of this is giving anyone Medicare Advantage flashbacks, you're correct, right? Like it's a similar vibe here. And the challenge is really knowing whether coding increases reflect truly more complex care that's happening or just higher spending for the same stuff. It's probably somewhere in between. Payers increasingly believe the latter, and they're pursuing these down coding strategies, which is why I call this the AI coding wars, because it's kind of a one-upsmanship approach. But I think what's really needed is learning more about how which types of AI are being adopted, what the implications are for, are we seeing the ones that truly drive value in healthcare delivery, or are we seeing the ones that actually in many ways magnify the flaws we already know our healthcare system has and the challenges we've been dealing with for decades. So I look forward to both participating in the discussion and hopefully participating in the research on this topic going forward.
Well, thank you very much, Hannah. You really hit hard on the upside, the administrative benefits and so forth. And we'll get a chance to talk a little bit more about prior auth, productivity, the happiness index, reducing turnover, really like that. And then the downsides about how it may increase access, which is going to lead to greater volume, greater costs. The care cascade. I know that Mike and Mark in particular can talk about what happens when you do images and you find stuff that are these kind of incidentalomas, I think is the term that comes to mind. The reanalyzing images stuff is going to just generate a lot of fines and detections and maybe false positives, and then the AI upcoding issue, which we may never escape. Thank you very much. Jeremy, so not everybody knows about you and Humata and its role. Can you kind of fill us in on that? And then I know that you're going to get into things like Wiser and multiple data streams and what have you. So Jeremy, a little bit about you and Humata first.
Good morning, good afternoon, friends. The only thing worse than following Abe Sutton is following Abe Sutton, then Mike, then Hannah. So here we go.
Okay.
Great to spend some time with all of you. My name is Jeremy Fries. I'm a recovering academic radiologist. I spent time at Mike's institution, then Hannah's institution, and now I'm a capitalist. I run a healthcare company where we're using artificial intelligence to try to solve prior auth. And the reason that I got to this space during my 20 years as a practicing physician at this little clinic in Rochester, Minnesota, I ran the finances for a $1 billion imaging department. And in that work, was my job to solve the back office BS that both Mike and Hannah have talked about. And frankly, we had warehouses of humans doing all of this work. And they're wonderful humans, and they did a fantastic job. And yet we were, even as maybe the most well-resourced healthcare organization in the country, it was still a pain in the butt. So I tried to find technology vendors to try to help us. And frankly, they didn't exist. I could hire the consultants, the McKinseys, the Deloittes of the world, but there weren't technology options. And it just became so clear to me that this was a technology problem to solve. And now this was 15 years ago, friends. We've come a long way since then, fortunately, but we still have a long way to go. The reason that prior auth is sort of the thing that I've hung my hat on, and now this is my third prior auth business that we've been trying to solve. The first one was provider focused. The second one was payer focused. And now at Humata, we're trying to solve this problem, as I like to say, on both sides of the fax machine. So why does prior auth exist? Prior auth exists because there's a bell curve of care in the United States. And you've got some really wonderful and some little bit less wonderful. And there's huge variability. And so both from a safety standpoint, but also from a cost standpoint, this prior auth problem has been I call it a problem, that the prior auth process has been in existence for decades. Historically, it's been dealt with by fax machines and Post-it notes. And now, fortunately, the world has recognized that it is a problem that has so many different variables that, frankly, a computer is far better at it than dealing with it by humans. And so at Humata, I'll just give 2 seconds about what we do and then lead into the work that we're doing at Wiser and why I think that is impactful. And I too, Cliff and Mike, feel it was a shame that Abe didn't mention it. We'll cover it for him. So we're primarily a provider-focused business. I'm a doc. I want to solve this problem for patients. And so what we do for providers is we work with large health systems to help connect into their EMR and understand, is an auth needed? Ladies and gentlemen, that should be easy to figure out. It's not. About 40% of the time, we're able to say an auth is not needed. Humans, stop working on this. The job is done. But the 60% of the time that an auth is needed, that requires an enormous amount of human labor. And what that means is they have to go to literally dozens of different portals, because each payer has their own little thing, gather the requirements, submit, go back into the EMR, find the information, submit it over through that portal, or yes, send a fax, and then they sit and wait for days, weeks even, to get the answer back. What we do is we help streamline that process so a computer does the whole thing instead of an army of humans, or that those humans are augmented. And what that means is the health systems actually submit fewer prior auths because they understand, is an auth needed or not. So you're actually improving the process for the payers, even if we're only on the provider side. They also submit better auths. So this whole problem of going back and forth is because they're not submitting the right clinical information. If you submit the right stuff, you're going to get more yeses, which is great for the provider and the patient, but you also have less administrative burden on the payer side. So that's our primary job that we do. Excuse me. We've signed up to be a participant in Wiser with Abe. And the reason is, if patients are going to get improvement in this process of prior auth, instead of waiting, in Medicare Advantage, it's now 7 days. In commercial, it can be up to 28 days. Instead of having to wait for a week to a month, a computer can and should be able to say yes, and can do it nearly instantly. And so what Abe and team are trying to prove is that a computer can say yes when the answer should just be yes. And let's not have all of this waiting. But if the answer is, you know what, I just don't know, then instead you have an army of doctors and nurses that make a decision. And so this Wiser model has now been rolled out in 6 different states. We have the great state of Oklahoma. Started in January of this year, so we're just 2 months in. It's a 6-year-long project for a very, very limited set of codes. So about 20 codes. These are outpatient codes. These are not things like chemotherapy for grandma. These are frankly outpatient procedures for the most part that have a known high percentage of fraud, waste, and abuse. And so we're one of the 6 participants in this program and have successfully rolled out. The other thing that's really important to note is two of the key aspects of the program are not only improving the efficiency on getting to more yeses, but also provider satisfaction and accuracy of the artificial intelligence. And all three of those components are an important aspect that Abe and team track on a quarterly basis, and release that information to the public as they deem appropriate. And so, we're just 2 months in. It's early in the data cycle, but what we're seeing, as one example, nationally, the number of providers that actually submit information by a portal instead of by a fax is depends on the location and the payer, anywhere from 1% to 80-ish%. What we're seeing, at least in our Wiser experience, is far higher percentage, and it's because providers are getting value by submitting that information and getting instant answers back. And so we're really excited about that, and we've got to leave it up to Abe and team on what and when that information gets released, but excited to frankly show that you can. And then again, I'll end with this particular point. As Hannah and Mike have talked about, there is definitely an AI war when it comes to a lot of the back office BS of healthcare, especially in coding. It's a zero-sum game. Provider wins, payer loses. Prior auth is a completely different circumstance. I'll say that again. Prior auth is a completely different circumstance when it comes to the utilization of artificial intelligence. When the provider has AI, it benefits the payer. When the payer has AI, it actually benefits the provider with one key important point, and that is the AI can never say no. And I'm a firm believer that when on the payer side, AI should never say no. It should take a doc, a nurse, someone that actually can understand the nuances of healthcare to finally make those calls. And that is exactly how the Wiser model is set up. And so I'll maybe hit pause on that and
So Jeremy, when
run from there.
So the Wiser is set up so that when the AI wants to say no, it kicks it over to a clinician or clinicians, and they would have to say no. Is that the point you're making?
100%. So the AI can say yes immediately as soon as the information is submitted. And so a doctor, let's say I'm a doctor in Oklahoma, I go to the portal, I submit the information on the portal, the AI runs through the clinical information and says, Eureka, you meet the NCD LCDs that are already these NCDs LCDs have been in place for a long, long time. The rules of the game did not change. The only difference is AI can now say an immediate yes. If the answer is, boy, not quite sure, doctor or nurse has to review it.
So just most people probably know LCD is local coverage determination, which has to do with Medicare, administrative contractors, coverage policy, NCD, national coverage determinations. So your Wiser is being applied to 20 codes right now, and you're sort of tracking three things: efficiency, physician satisfaction, and accuracy.
Correct.
With regard to training the AI, I just want to make sure I understand something. So basically, you pump into the AI the NCDs and the LCDs, but do you also train it? Like, have you trained the AI with human feedback about, thumbs ups or thumbs downs?
So we're a provider-facing business, and so we've done tens of millions of prior auths across every single payer in the country. And so what that means is
we've got training material. Yeah.
We've got yeses and nos and the clinicals associated with it, like Mike talked about, for every payer in the land and every CPT code in the land. And by being able to do that, you have the training material to do the same work that we're doing with Abe and team.
Got it. Jeremy, this is great. And kudos to you that 15 years ago, you were thinking about stuff that most of us are just realizing now. And also recognizing your background as a radiologist. And that's one of the areas in which AI is at or near the forefront these days in clinical care.
I can't tell you how much it makes me smile that we're talking about incidentalomas and prior auth in the exact same conversation. This is as good as life gets for me, friends.
It took me a while to find that term.
I love it.
So Hannah, did Jeremy kind of lay it out to you in a way that makes sense? Because I know that you looked at the administrative side of AI, including some of the points that he made. Is Jeremy on the right track here? And is Humata kind of doing the right thing by how it's kind of starting into Wiser? What do you think?
I mean, I think it was fascinating to hear about this and to hear about the journey that Jeremy has taken to be where he is now. I think that the only part I didn't have a great handle on, and this is probably my, I know about Wiser somewhat, but probably not the exact details. Um, Tell me more about what success looks like. Are we trying to reduce the utilization of services that have a high potential for fraud, waste, and abuse? Is that part of the incentive structure for participants?
So uh, I didn't go into those kind of details. Yes, certainly what Abe and team are aiming to show. Obviously this is a question for him more than for me, perhaps, but uh, the the reason they started in these first 20 codes is because there is a believed belief that there's a high amount of fraud, waste, and abuse in these codes. And so not when I think about this problem, and the reason I think this is important work is we have to think about both the American taxpayer and the American patient. And so if we're doing, I'm just going to throw out, and I'll go back to my clinical days. 25% of the patients that we would overread images for in my former life, we would change the diagnosis or change the care plan. That means that grandma was getting a surgery or getting some care plan that was not appropriate. So the goal of Wiser, and frankly the goal of prior auth, is to make sure that 25% or whatever the number is, people aren't getting surgeries that you don't need. That's not good for the patient. It's also not good for the taxpayer because we're paying for things that are not actually improving care.
Fair enough. Mike, do you think that Jeremy's sort of economics are going to work here insofar as Wiser being truly a value-driven model in the way Jeremy's and Humata is kind of carrying it out? You have high hopes for this?
Well, I have high hopes for it because I know Jeremy, but I think that's a little bit besides the point. Um, there's, you know, CMS has done a lot of things. This is the type of thing that fits exactly into why CMI was set up. It is intended to test various things. As Abe laid out, he didn't lay out on Wiser, but he laid out for some of the other models. There's always this theory for the case. And what ends up mattering is the execution and how it plays out. One thing that we didn't talk a lot about in some ways is like how Jeremy gets paid or how Humata gets paid and how whatever savings they generate gets split between Humata, their providers, the taxpayer, in a bunch of ways. So from my conversation with CMS, there is a fair bit of money on the table. It's a relatively prescribed set of services. And I think, Mark and I wrote something in Health Affairs that pointed out that you can't really, in traditional Medicare, go too aggressive into care denials in a particular way because the traditional Medicare program is not intended to interfere with the practice of medicine. So there's some discretion about what that means in practice for some of the particular services. But the CMS folks tell me that there is such variation, which is what Jeremy led with, that there is a significant opportunity there. And if you can get the bell curve a little less bell, anyway, you can have enough money to go around. Am I optimistic that will happen? Probably depends on my level of caffeine and sugar. But what I told Abe at the beginning was that if your goal is to make the healthcare system more sustainable and you're trying to lower spending or at least spending growth, you're going to focus either on price or quantity. And if you look in Medicare, and this is something I know well, the prices are already set to rise at a very low rate. So you need to focus on quantity. The problem with focusing on quantity is you don't want to impede access to high value services, which has been the entire mission of the VBID centers, to make sure people get access to high value services. So you got to focus on low value services. So just the attention to low value services and the willingness to bring new tools to go into that space warms my heart. Whether or not they're successful at doing it, whether they can get the voluntary providers to sign up, whether they can have a financing model that works long run, whether there aren't any other unintended consequences, I tend to by nature be skeptical of those types of things. But skepticism in a world where you have to act, skepticism shouldn't create paralysis. And so I'm just waiting to see how this plays out. And I think Jeremy said they have such data and they can throw just the level of computing power they can throw at this problem dwarfs what they could have 5 years ago.
So
So we'll see.
thank you, Mike, for that. Point well taken. Jeremy, Mike just raised the point again about data. Tell us again, it was cool that you said you got what tens of millions of prior auths with which to train your Wiser model. What are the multiple types of data streams that at least currently and or in the future may be sort of pulled in to the AI models to make even more accurate, more efficient decisions? What kind of data are you basically hoovering up to make this
So
work?
I think about it in a couple ways. So the first is to really do prior auth well, you have to understand medical policies, whether that's for the government, NCDs, LCDs, or commercial plans or MA plans, the medical policies. These medical policies, for those of you that don't know, are 20 to 50 page PDFs. Literally 20 to 50 page PDFs with like, A, B, C, D, a gazillion different things. A human has to try to read those and understand, wait a minute, do I need 6 weeks of physical therapy or 42 weeks? Or like, what do I need to do to get to yes? And so that's a challenge. So one piece of data is understanding these medical policies. The other piece of data is the clinical information. And the
So
clinical information.
hold on,
Yeah.
time out. So the PDFs are they're unstructured narrative data, which
Yeah.
is a lot different from other sorts of data, right? You need different kind of ability to intake streams that are much different sources and types of data, right?
It's mostly we're mostly dealing with an unstructured data problem,
With
friends.
unstructured.
Yeah.
Yeah. That's
Mike's
tough.
got his hand up.
Yeah, Mike.
So I think the key challenge here, so I 100% agree with that value statement, as Jeremy said. And if you look at any of these types of things, you realize why it is so labor intensive to sort this out with someone. I once was in a seminar where someone had a binder on these things and they're just going through these binders. That's page 45. It's just impossible. The tools are so much better. The trick is some of the things in these binders don't lend themselves to turning into data. Is this sleep apnea? Is this interfering with your quality of life? Right? So if all the rules were about what's your ejection fraction or I don't know, what's your hemoglobin A1C, then I'm completely with you. But when the rules get to be, are they, how are you in significant pain? Otherwise, you can't do it. Essentially what has to happen is the technology has to sort through how they're going to interpret that. And then you get a bunch of back and forth between, this, and eventually you could get into a situation where the provider just learns, check off they're in really significant pain and they can't move their pinkies. And then everything just goes through. And so what is unclear, and I really hate to say this, it's good, I wish all these meetings were in person, but sometimes you say things where you're glad it's not. This is one of those times. And what happens is the secret to prior auth might not be the actual substance. The secret of prior auth might be the ordeal of prior auth. And the concern that I would have, if Jeremy makes everybody happy, and by the way, in case you're keeping notes, I want everybody to be happy. But if Jeremy makes everybody happy and gets rid of the ordeal, that could be amazing. But it might be the ordeal was actually causing the dampening of the utilization of some of these things because the barrier was documenting things that just don't show up in a very auditable way. And that's that's kind of this sort of skepticism of where we are in this particular things. And I think it's the challenge of the overall model is the vagueness of indications for some of the very specific things that are going on.
Love the economics of human behavioral economics, right? It looks like a hard thing to do. Hannah and then Jeremy.
Sorry, I just raised my hand the old school way, not the Zoom way. I think that Jeremy, I suspect that conversation we just had probably ties into the statement you made, which is that the AI only says yes or maybe, right? Is that why, like, do you think there's a world where the AI ever gets to a point confident enough to say no, or will that always be the human in the loop?
I mean, I have a bias. I'm a doc. And so I think what Mike talked about is there's a lot of gray in these medical policies. There's a lot of gray, and that's true in commercial or in the Medicare world. And I mean, in today's world, I just don't trust the computer to say no. And frankly, I think you could make an ethical argument too to say, should a computer say no to, grandma's whatever? I would argue no.
Not my grandma's whatever, I'll tell you that.
Yeah.
Well, by the way, Abe Sutton probably didn't talk about Weisler because he knew we were going to talk about Weisler.
There you go.
And
We'll give him.
he was being
Yeah.
very generous about time allocation for that. Well, thank you very much, Mike, Hannah, Jeremy. This is great. A lot of important insights into how we actually put this stuff into practice. Hannah, I know you're leading the charge there at the U of M on the AI stuff and all your pros and all your cons. Mike, I think you're going to take this home to all the great things that you're doing, MedPAC, Harvard, and everything else. These are all great insights. Jeremy, hats off to Humata. You're ahead of the curve, and we look forward to seeing how this all plays out. Thank you all three very much.